Professor Chen is a staff surgeon in the Koo Foundation Sun Yat-sen Cancer Center in the colorectal unit. He's the assistant director of the institution Colorectal Cancer Multidisciplinary Treatment Team. In 2011, he was appointed member of the Taiwan National Health Research Institute Colorectal Cancer Consultative Panel, in which he played a key role in monitoring colorectal cancer treatment quality markers and determining nationwide treatment recommendation. Since finishing his residency, he has taken particular interest in laparoscopic colorectal surgery. And the thing is that he has further advanced his skills by undergoing advanced laparoscopic surgery fellowship with Jeff Milson. And once upon return to Taiwan, he began performing single port colorectal surgery, which is now becoming the standard of care in his primary institution. But perhaps more pertinently is that in 2013, he completed his first transanal TME operation before many other institutions worldwide. He published in Surgical Endoscopy and Annals of Surgical Oncology, and that was when I met him in 2016. Aside from TLTME, he also does robotic surgery and has experience in the Da Vinci Xi system and has even incorporated that into the TLTME platform. So I think that there's none other better person to perhaps guide us on the best approach to low rectal cancer than Professor Peter Chen.
Ladies and gentlemen, this is Peter Chen come from Taiwan. It's my honor to be a part of this hybrid webinar. Thanks for the invitation from Congress organizer. I like Singapore and have many good friends there. Hope we can catch up again very soon. My topic today is the best approach for low rectal cancer. I have no disclosure to this presentation. Please allow me to introduce my background for a couple minutes. I started my laparoscopic surgery since 2007 and as the clinical fellow in New York Weill Cornell Presbyterian Hospital under the Professor Milson in 2009. I started to do TLTME since 2013, and my hospital is the first center opened for Q3 trial patient recruit in Asia since August 2018. I got my robotic surgery certification in the end of 2015 in Sunnyvale, California. Early this year, I'm the first one who got official TR300 trainer certification and organized the first course recently in Taiwan. I'm married, have an 11-year-old boy, and my favorite hobby is Lego bricks and watching baseball game. The goal of my talk today is setting as update the modalities treatment for low rectal cancer and introduce how I combine the different approaches and maximize their advantages. Clinically, we have to face many difficult rectal surgery cases, like shrank low rectal lesion after neoadjuvant treatment, large uterus, narrow pelvis, tissue become edematous after irradiation, recurrent rectal cancer, and obese patients. These factors make rectal cancer hard, like the pelvis is narrow and deep, bleeding issue, diversity between patient and the current technology is not perfect. That's why in the textbook, the rectal surgery was described as no man's zone. In the past several decades, the treatment results of rectal cancer got large improvements due to these innovative concepts and techniques, especially the TME, which is proposed by Professor Hield. Today, I'll focus on neoadjuvant treatment, TLTME, robotic surgery, and TMEs. Firstly, I want to clarify some concepts. Clinically, we have a problem and expected a certain result. The role of neoadjuvant treatment is to change the nature of the characteristic of the problem. Then we have to find a method of approach to achieve the goal. So transabdomen, transanal, or localization are approaches and may relate to different results. Then we have to find a appropriate tool according to different approaches. Open, laparoscope, and the robotic platform are tools. Nowadays, probably robot is good for transabdominal approach, and laparoscope is better for transanal. In the first part, we talk about the neoadjuvant treatment. My hospital is the first to adopt the neoadjuvant chemoradiation for rectal cancer treatment in Taiwan around 1995. In the past 2 decades, we modified the protocol many times. Some successfully improved the result, and some failed. Like we found added cetuximab to neoadjuvant chemo regimen didn't bring any benefit, but increased the risk of surgical complications. This is our latest protocol in the past 6 years. We also limited the indication to patients with threatening CRM, T4, thyroid lymph node positive, and potentially convert to sphincter saving instead of all the T3 or ERM positive patients before. We use a short course radiation with a 2,500 centigrade in 5 days, and followed by 3 courses biweekly FOLFOX after 1 week off, then restaging and go on surgery. The interval between the start of radiotherapy to surgery is around 12 to 13 weeks. And most of the patient will have an enterostomy reversal in 2 months after the primary surgery. Last year, we did a retrospective study to compare the different neoadjuvant treatment protocol in our practice, which include a conventional long course CCRT, short course with immediate surgery, short course with delayed surgery with capecitabine or FOLFOX regimen. This is one of the comparative table in our article. Short course with immediate surgery have highest post-op complication rate, and the short course radiotherapy with consolidative 3 courses FOLFOX have lowest post-op complication rate, distant mets, and the 2.2% local recurrence rate. Our overall local recurrence rate is 4%. Another table showed in the group of short course with delayed surgery and the FOLFOX regimen, over half patients have a PCR or a nearly complete remission. Further analysis, we also found the tumor regression is correlated with a CD3 and a CD8 cytotoxic lymphocyte infiltration or densities. This article is published in August last year. Let's see the result of Rectal trial, which is similar to our protocol but more chemotherapy courses. It compared the short course followed by CAPOX and the delayed surgery with conventional long course CCRT. The short course group had more PCRA, fewer disease-related failure, and a better 3 years disease-free survival. In the other hand, similar local recurrence rate, R0 resection rate, and the quality of life. In the combination of our best approach, we adopt the short course radiotherapy followed by 3 courses FOLFOX and a delayed surgery as our first option. And now we are planning to extend the chemotherapy to 6 courses. Then we move to the surgery. Of course, minimally invasive surgery is the main trend at this moment. Laparoscope is definitely a revolutionary innovation, and is one of the matured options for rectal cancer surgery, even without randomized control trial backup. But all problems is still there after decades of development, like a difficult pelvis, instrument limitation, and the steep learning curve. In nowadays, probably laparoscope had reached the summit. From the viewpoint of technology, robot had lots of advantages, like the wrist function offers more possibilities of movement, decrease the physical stress, innovative advanced instrument, build up a complete solution. The most important point is the robotic platform minimize the technical variation between surgeons. And I truly believe that's one of the core value of robotic platform to the clinical practice. Da Vinci Air robotic platform once have been the hope that may help surgeons to overcome rectal surgery. However, the rollout trial, which is published in 2017, failed to prove the superiority of robotic platform. About 2 major factors, conversion rate and the circumferential margin involved rate. There are no difference between conventional laparoscope and the robot. In the other hand, how about the real world? Since the XI system entered into the market in 2014, the penetration rate of robotic system in general surgery field increased very fast. This was the data in 3 years ago, showed the health of the colorectal surgeon use robotic system in United States. And 83% of colorectal fellows had been trained to use a robotic system. I believe the percentage is definitely higher now. This video clips demonstrate how the innovative technology of robotic instruments makes our practice different. Like the linear stapler with artificial intelligence, which can help to decide when and how to trigger the stapler. The articulated advanced bipolar vessel sealer offer the more working angles and make the surgery easier, especially facing difficult situation. Reach the function to facilitate the suturing and integrate the ICG image to evaluate the blood supply and as guidance to identify hot lymph nodes for cancer patients. So make a short summary for the current position of robotic system. It is the innovative technology, no doubt. Shorten and flatten the learning curve of minimal invasive surgery. The robotic system simulate the open technique in the minimal invasive environment. It's a very important concept. Better outcome confirmed by randomized control trial. Probably no more trials will be conducted in the future. Not only for rectal, but for all colorectal surgery, especially after innovative instruments enter clinical use, and enormous possibilities to involve in the future. About TLTME. I think the basic concept of TLTME is pretty simple. It's just because of the target is too far, too deep, and too narrow in space, so we change the working direction. This concept originated from TATA procedure and realized by modern minimally invasive instrument. Cadaver model since 2009, case report in 2011, and 2013 is the year of TLTME, as Professor Hill said. The surgeons around the world worked and shared the experience together to develop this innovative technology and move it forward. Until this April, we had performed over 470 TLTME procedures in the past 8 years. These are the works we do during this period, include early technique development, organized structure training, multi-center data registration, innovative indication like transperineal minimal invasive APE, and combined robotic and TLTME. Functional result evaluation, the paper was just accepted in recent days, and the long-term oncological result analysis. COLOR3 trial is an international randomized control trial, which compared conventional LAB-TME and TLTME. The primary endpoint is 3 years local recurrence rate. Since July 2018, our hospital is the first center opened for COLOR3 trial patient recruitment in Asia area. Until this July, the recruited and randomized patient number is over 600. We contribute 50 cases and is number 4 in all centers. These are the potential benefits of TLTME approach compared to top-down lab surgery. They include precisely define the distal margin under direct vision, better anatomy and identification for distal third part of rectum, significantly shorten the operative time. I mean, 2 teams socio approach, better chance to achieve complete TME compared to LAB-TME. TLTME is 97% versus 72%. Better functional result, especially sexual function. Similar oncological result, at least. And these are the opinions according to my personal experience. I think it standardized the single stapling anastomosis in every patient. And the TLTME can decrease the anastomosis related complication. The best chance to achieve sphincter saving. And it's my most confident approach to have a similar low rectal dissection quality in every kind of body type. I'll go into details in some points after. Which is different from top-down lab surgery is TLTME divide distal margin in the beginning and under direct vision. Because of a longer distal margin do not bring better oncological result and may have a negative impact to functional result. So I preferred to say TLTME can get a proper right distal margin, but not necessary to be a longer one. And I think TLTME provides the most chance to achieve sphincter sparing. For mid-rectal lesion, we can identify the lesion by transanal view and put the purstring suture like I mentioned in the last slide. It can guarantee a proper right distal margin length in the beginning. And for atrial low lesion, the intersphincteric dissection can be performed under TLTME approach. The video camera and the air seal system provide a clear surgical vision and a stable surgical field compared to the conventional open method. And this is the case of anastomosis stricture after robotic low anterior resection. We are going to revise the anastomosis. The TLTME technique divide the rectal stump close to the stricture site in order to preserve the most length for the new single stapling anastomosis. We modify the whole order, divide the rectum first, then close the lumen by purstring suture later. Like this, we divided the rectal lumen, then we do the purstring suture to close the lumen. Then we start to do the TLTME. About the anastomosis, now we know TLTME won't increase the chance of a hands-on anastomosis, which is worried in the early phase of development. The published evidence shows a similar leak rate compared to double stapling technique. But personally, I have different opinions, and my data favored single stapling under TLTME could have a less complication rate of anastomosis. But one thing for sure, TLTME provide a unified standardized method to do anastomosis. This is the single stapling anastomosis in patient with a neoadjuvant treatment 5 days after the surgery, located in 3 centimeters above the anal rectal junction. This is in patient without a neoadjuvant treatment. Same patient in 1 year later. I think it's the best one I can do. The denovilized fascia is an important landmark in rectal dissection, which is also critical to the functional preservation. This is the robotic top-down dissection. And let's move forward. And yes, under the robot, you can clearly identify the proximal side of this denovilized fascia and preserve it precisely. But under TLTME, can identify the distal side of the denovilized fascia as well. You choose to enter into or stay outside the fascia according to the location of the tumor to get a more circumferential margin or preserve the fascia. So robotic above, TLTME below. This is my favorite combination to do low rectal surgery and allowed us to deliver the best surgical quality efficiently. We can use this surgical picture to make a short conclusion under TLTME approach. We can identify the prostate without open the denovilized fascia and bilateral neurovascular bundle clearly and precisely preserved. This short video clip showed when bleeding was happened in the prostate surface and deep in the pelvis. Under TLTME approach, the bleeders could be identified very precisely by inline vision and take care by suction with a diathermy without too many traction. However, when you see the same region from top-down approach, it's hard to expose the prostate surface even under robotic platform. I believe that every colorectal surgeons had similar struggles before in this area. In last year, we did a long-term survival analysis of 400 rectal cancer patients who received the TLTME in our hospital during the past 8 years period. The circumferential margin involved rate is 2.3%, 5-year local recurrence rate is 4.8%, and the median follow-up interval is 55 months. Compare our data to other published series, not much difference. I think we have enough evidence to believe for a mid to long-term concern, TLTME can provide at least a similar oncological result compared to other standard approaches. So make a short summary of the current position of TLTME. After years of development, it is a mature procedure with standardized steps. I believe in experienced hands, TLTME can deliver optimal function and oncological results. Beneficial for low-lying lesions, definitely, and the ongoing Colorectal trial will clarify its position in the future. Regarding about the surgical approach, especially for low rectal lesion, I prefer the TLTME with simultaneously transabdominal approach. That's my best to guarantee the same dissection quality in every kind of patients and help me to handle challenging scenarios. Let's move to how I integrate the multi-surgical modalities. Our first try is duct the robot platform in transabdominal approach to do robotic TLTME and assisted by another team in abdomen doing laparoscope transabdominal approach. The result of 20 cases is published in Asia Journal of Surgery. My original goal is using the advantages of wrist and the stable camera of robot to facilitate the TLTME procedure. We put a single port platform gel point in the pre-designed loop iliostomy side and another additional assistant trocar in right upper quadrant to do vessel ligation, sigmoid mobilization, and sometimes partial splenic fracture takedown. This is how we duct the robotic system between the legs. I have to say, it's hard to set up the SOP of how to duct the robotic arms under lithotomy position, even we just use the 3 arms only. This short video showing how the robotic doing TLTME dissection. As we anticipated, the robotic platform offers a stable surgical field and the traction. The hashiers is sharp and effective, but sometimes it's still too crowded to doing the works in a very narrow lumen. But sometimes we can switch our hands to facilitate the dissection. Especially when you have to do the suturing, definitely the wrist helps a lot. This is the first series report of this combination. 20 cases collected with 1 conversion, 35% peri and the post-op complication rate, and the uptime is around 3 hours. Our reflection wrist function is useful, not only for dissection in small area, but also helps a lot if you have to do suturing. As I mentioned before, it's not easy to duct the robotic between legs, even just use 3 arms. Personally, I think the ultimate solution should be integrated system like Da Vinci SP or a more advanced type in the future. But as I know, even you have a Da Vinci SP system, the ducting is still a difficult issue. That's the information from Simon from Hong Kong, who probably did the most transanal surgeries by Da Vinci SP system. So it's feasible, but not practical. We quit after 22 cases. Then we reversed the combination. Personally, I think the robotic system did a better job in transabdomen surgery and offered the most solution when dealing tough cases. On the other hand, do the distal part of the rectal dissection by TLTME technique is my best to guarantee the oncological and the functional results. So robotic above and the lab TLTME from below. This case series was published in Journal of Robotic Surgery early this year. The figure shows the operative theater setting. For low rectal cases, mobilized splenic fracture is a necessary step. I do the reducting during the surgery. I routinely put a single pole platform gel point in the periumbilical area. After mobilize the splenic fracture, the robotic is reduced and targeted to the pelvis. At the same time, another team doing laparoscope TLTME simultaneously. We use the robot to occlude the rectum, ligate the vessel, doing posterior TME dissection and the lateral dissection. Simultaneously, TLTME procedure meet each other in peritoneal reflection. This is the robot view versus transanal view. You can tell the TLTME view helps to identify the prostate and the neurovascular bundle easier and more clearly. We collected 69 cases within 2 years, with only one conversion, 10% complication rate, and less than 3 hours mean surgical time. The Color 3 trial include this practice combination and might have the relevant related analysis in the final report. For this combination, the robot systems simulate the open method, offer more possibilities under minimal invasive setting. The single port device increase the flexibility of port arrangement and maximize the cosmetic result. Simultaneously approach, shorten the theater time. And I truly believe TLTME is better in low rectal dissection. So this combination is my ultimate weapon for low rectal surgery. For the surgical modalities, I think every tool have its own best position. Currently, robotic platform is my option for transabdomen top-down dissection, and the laparoscope is still the best one for transanal approach. However, the evolving continues. New instruments or platform will be available in case the demand is there. Let's move to the last part, shortly talk about the transanal wide incision, which might be a reasonable choice for early rectal cancer and the lesion which is well responded to neoadjuvant treatment. These are the conventional indications of transanal wide incision for rectal cancer, include early, small, distal, and the need post-op adjuvant radiotherapy, very limited. Because of the introduce of the transanal minimal invasive surgery, TMEA, in recent years, the indication expanded to well-responded rectal cancer after neoadjuvant treatment, shrunk the rectal GIST after Gleevec, mid to high rectal neuroendocrine tumor without the risk factors. This fast video demonstrates the procedure transanal excision under TMEA technique for a T1 lesion in polyp, post polypectomy with involved deep margin. As you see, we can do a full thickness excision, and the mesorectum can be exposed clearly identified. Then repair the defect by VLAC simple suture. Okay, we can see the mesorectum here. Then we do the suturing to repair the mesorectum under the direct vision. Another case of mid-rectum T2 lesion, because of the patient had ovarian cancer, post debulking surgery and under chemotherapy. We choose a relatively less invasive procedure for rectal cancer. Not standard, but fortunately, no recurrence for 3 years till now. About the indication of local incision for post-neoadjuvant treatment rectal cancer is still controversial. No doubt, it's truly organ and functional preservation. But the issue of lack of lymph nodes evaluation and the poor wound healing are under debate. Grieger 2 trial, which is published in 2020 last year, compared the local incision versus standard TME for well-responded rectal cancer after neoadjuvant treatment. Totally 148 cases divided into 2 groups. Almost all the oncological parameters are comparable in 2 groups. The most important is local recurrence did happen in local incision group, but all confined endoluminal, no pelvic lymph node spreading. These are the messages of what Grieger 2 delivered. Most are reasonable and acceptable, but the trial conclude that for a well-response tumor, regional lymph nodes is not an issue to be concerned. I don't agree with that, because we did have patients have clinical complete remission, but the enlarged lymph nodes persisted and noted under the MRI. The followed surgery confirmed the residual viable cancer cell in the lymph nodes. So I think we need more evidence before adopt the local incision as a standard option for well-responded rectal cancer after neoadjuvant treatment. There are some take-home messages. The protocol of a neoadjuvant treatment for locally rectal cancer is involving short course radiotherapy followed by chemotherapy, and the delayed surgery should be the default in the future. After years of technical improvement and evidence support, TLTME is a mature option for mid to low rectal surgery. Did it provide a better result, especially the oncological result? We don't know at this time, probably, and we need the color 3 to prove that. DaVinci Xi platform is an ultimate tool for transabdominal approach rectal surgery, which can minimize the variance between surgeons and with enormous potential to involve. And the last, the indication of local-wide incision for rectal cancer is expanded and refined by Tommy's technique. However, it needs more evidence to clarify its position, especially for the lesion with a well response after neoadjuvant treatment. I want to share a sentence from Stephen Hawking. He said, the greatest enemy of knowledge is not ignorance, it is the illusion of the knowledge. I think for every innovative concept, technique, or instrument, you need to understand it before you use it well. And thanks for your attention. And every questions are very welcome.
Thanks so much, Peter. I feel so educated. The thing is that
thank you.
It's such an enlightening lecture. All right, is there any question from the floor? Maybe I start first. The thing is that, Peter, over the last decade and your own experience over the last 20 years, you have seen many evolution of how rectal cancer surgery evolved. But fundamentally, it's about different techniques from the top, from the bottom. The thing is that, what do you think will be the next frontier for rectal cancer surgery? And do you think that AI and fully automated robotic will come in, like the way that the machines will take over surgeons?
Okay, thank you. Yes, for the past 2 decades, the technique involving, and it's I think it's a very exciting period for us, especially for the surgeons, yeah, because we got new stuff and new concepts every few years. But I think the most fundamental concepts is the same. That's the TME. That means the actually, no matter how the techniques, the skills change, but the fundamental themes is the same. No matter we use the laparoscope, robotic, or TLTME, we just want to catch up the result of TME. So we just want to be similar or be equivalent to the open TME result. So that's what we are doing now. We just to minimize the trauma to the patient. So I think that the next frontier or the cutting edge should be the robot, no doubtly, because the robot have a lot of potential to involve, especially the AI, artificial intelligence. Like the instrument, the robot now, like I mentioned, the linear stapler, or in the future, the augmented virtual reality will add it to the robotic surgery. I think the most advantages should be emphasized in the increase the safety of the patient to minimize the trauma to the patient. So why I use the transanal minimal invasive as the last part, because I think the surgeon's goal is to preserve the function and to minimize the trauma. So one day maybe we will know how to pick up the most candidate. They don't need the surgery, like watch and wait or something. Should be the next step to separate the patients to many groups, not only in the stage 1, 2, 3, 4, but maybe 10 groups or 20 groups. Yeah.
Hey, thanks, Peter. Is there anyone from the audience?
Yes. Yeah, yes. Jimmy. So, Peter, Jimmy. Excellent lectures.
Hi, Jimmy.
And I think this is a fascinating topic on low rectal cancer. I'm upper GI surgeons. I also very fascinated by your topics, and I'm very delighted to hear that you're also doing clinical trial to validate such a variety of surgical techniques for rectal cancer, like robotic AR, laparoscopic AR, and your TLTME. There are 2 questions. One is I may have missed that you're doing a color trial. What is to look at the TLTME? Can I see what is the trial design? and what's the update on this trial? And second is, one of the approach you are doing for rectal cancer is wait and see, which is similarly what we are doing it for esophageal cancers. And right now, I think in Europe, they are doing the, for esophageal cancer, a wait and see randomized control trial. And what's the status on wait and see in rectal cancer? Yeah, thanks. Thanks, Peter.
Okay, thank you, Jimmy. For the first part, I think that the COLOR3 trial, actually, if you follow the whole development progress of the laparoscope surgery, you will know the COLOR trial, COLOR2 trial, and now it's the COLOR3 trial. Actually, they are the same group to doing that. So they have a many experience about how to conduct the trial. So this surgical trial, I think is a very well designed about how to validate the surgical technique. So it's approximately will recruit around 1,100 patients, and the proportion is 2 versus 1, 2 TLTME versus 1 laparoscope surgery TME. The primary endpoint is the 3 years local recurrence rate, as confirmed by MRI. And during the trial recruitment, every patient's every surgeries have be recorded and uploaded to the center for the central audit. So it's a high quality trial. And now at almost 50% health patients was recruited. Most of the patient was contributed from Asia, especially the China, because as we know, the China have a lot of the patient source. So yes, a lot of the patient was contributed from China, and the estimated close time will be within 2 years. And after 3 years follow-up, I think the final data will be available in 2015 around. Yep.
So is this COLOR3 trial, is robotic is included, is part of it, or?
Yep. Robotic was included in the top-down surgery. So the top-down surgery group included the laparoscope and the robot. And the transanal group was, the TLTME group will be included with robotic above or laparoscope below, or laparoscope above, laparoscope below. Yeah. So they recruit the main kind of patients. Yeah. And the second one is watch and wait. I have to say in Taiwan, now, I think because of the culture, of the East country culture, actually we don't provide a watch and wait as a standard option or the first option to patients, because we still worry about if the patient got recurrence, will got some legal problem, or our trust will be break out. So actually we don't offer the watch and wait as the first option, but now we are trying to let it be like we do is a SDM, shared decision making with the patients. So we will talk about watch and wait, but we will emphasize the risk and once the recurrence happened. So it could be a life-threatening status to patient. So I have to say, yes, as I know, our thoracic surgeons usually discuss this issue with me, because we have many similar scenarios about esophageal cancer and rectal cancer, especially after the neoadjuvant treatment. Yeah, very similar. Yeah, we learn about a lot from the esophageal cancer, but we don't provide it as a routine and option for patients. But as I know, in Europe, they did provide a watch and wait as a standard option to patients, but not in Taiwan. Yeah.
Thanks.
Maybe one last question, Peter, for me, is that for anyone who completed their fellowship or training, the thing is that you're hoping that robotic will be the way to go, which I sort of concur in a few years' time. The thing is that they also want to do TLTME. The thing is that, would you recommend that they should start both concurrently, or would you recognize that it's better to start with robotic to be good at robotic top-down, or to start at TLTME from bottom up before they adopt the other one? Which one do you think is more intuitive for them?
Yeah, I think that the young surgeons, they are really tired because they have to learn open, laparoscope, robotic, now TLTME. Compared to me, in 20 years ago when I in training, I just do open surgery. And as I see my teachers, they do open surgery only and do it for 30 years. So I think that after the training, I think the most of the young surgeons, they have to be as a fellow to learn advanced surgical technique, no matter the TLTME or robotic. And I truly believe within 10 years, the robotic will be a very popular and a very standardized approach, because I believe the robot is just a tool. And the young generation, they know how to play the video games. So I believe that they can adapt the robot very fast. So I don't worry about the robot. I think they just need opportunity to learn that. And we can create a standard and a very useful pathway for them. But TLTME is different because it's an approach. It's not a tool. So you have to re-understand the anatomy. So maybe it will need a long way to go before you know how to be familiar with that. So I think the robot should be learned first. And I don't worry about that. It should be true in the near future. But the TLTME should be learned after you got matured. Yeah.
All right. Hey, thanks, Peter. Thanks so much. I think that there's no other question. Thank you so much, Peter.